It is already quite late. It's 3 o'clock, so I think we should really start. Once again, a warm welcome to all of you being here. I see really that the number of participants is increasing at the moment. And welcome to the national and international colleagues and friends joining the Australian and New Zealand Society for Sarcopenia and Frailty Research Symposium. I am Andrea Meyer, the president of the society, the ANZSSFR. And before giving the floor to our excellent speakers, and we really have excellent speakers today, in a short, of course, update what we are going to do with our annual meeting, which had to be postponed because we would be now in Brisbane. I would like to acknowledge the traditional owners of the lands on which each of us is living, learning, working, and enjoying, hopefully, this symposium from today. Knowledge, of course, and experience is a key to success of future generations, and therewith I pay my deepest respect to our elders, both past and present in our countries. We are meeting today virtually, which is unfortunate, but this is the reason because it was quite unpredictable for the organizational team if we would be able to travel to Brisbane and to meet each other in person and to learn more about sarcopenia and, of course, frailty, which are the two very frequent conditions at older age. And I'm very happy that Professor Ruth Hubbard agreed to still be the host of our annual meeting next year, hopefully in person, but we will also give the opportunity to the ones who cannot come to Brisbane, of course, to join, so we'll be hybrid. And I will also tell you that all the speakers, because we had a wonderful program which would have kicked off today, that every speaker agreed to be still on the program and to attend next year, which is, of course, wonderful. I am thanking Nina Wiltshire, who is our new ANZSSFR administrator in the background at the moment of this symposium in preparing actually today's meeting. And we have our annual general meeting today for our members, so please remember to become a member. It would be great to have you on board on the ANZSSFR. And before doing so, in starting the annual general meeting, we have two excellent speakers. And the first speaker is Professor Maria Fiatarone Singh. Hopefully I pronounced it correctly. She is a geriatrician, as lots of us in the room are, and does great studies focusing on the integration of medicine, exercise physiology, and nutrition. I think this triangle is very important to improve health at older life, and especially the quality of life across the lifespan. And she is the inaugural John Sutton Chair of Exercise and Sport Science in the Faculty of Health Sciences at the Sydney Medical School and at the University of Sydney. And she will tell us the latest evidence about exercise for frail older people. So Maria, thank you for being here, and we are looking forward to your talk.
Thank you. Everyone can see my slides, I think.
Yes.
Thank you so much for the opportunity to speak today. It's really an honor, definitely, to be here and speaking to a crowd of like-minded individuals, hopefully. So I'm going to talk about exercise for frail older people today. And as you've already heard, obviously the interplay between sarcopenia and frailty is quite strong. Sarcopenia was first diagnosed or named 34 years ago. It's taken 29 years after that before it actually got its own ICD-9 code. And I think the problem that we face now is that although we have a lot of information about epidemiology of sarcopenia and progression and those kinds of studies, we really don't have the clinical infiltration of the treatment of sarcopenia to the extent that we should. So I think what I'd like to present today is some of the evidence that, in fact, we do have a treatment for this condition as well as for frailty, and talk about how that looks in practice. And obviously these two syndromes overlap, although they are distinct. Not everyone who's frail has sarcopenia, and conversely. And although there are genetic influences, I think the majority of what we see clinically in terms of sarcopenia and frailty really comes down to lifestyle changes and the accumulation of perhaps toxic exposures. So it is hard to define frailty and sarcopenia. We know it when we see it. But the definition is certainly something that has evolved over time. And as again, all of you would know, one of the most widespread definitions of frailty would include many factors that are actually quite closely related to sarcopenia, which means that the use of anabolic exercise for frailty becomes really quite central to its treatment. And although physical fitness is one aspect of the prevention and treatment of frailty, it's clearly not the only way that we need to think about these syndromes, but it is the one that we'll focus on tonight. So what is the purpose of trying to intervene? In some ways, what we're really trying to do is change the trajectory of aging so that we can age a bit more optimally. And if people have already descended into pre-frailty, frailty, or even disability, hopefully with robust kinds of treatment, we will be able to reverse some of that trajectory. And that's what I'd like to show you tonight. So I think the most important fact about these syndromes is that we really do not have any drugs currently that treat aging, frailty, mobility impairment, and the comorbidities and risk factors for these conditions. And if you look at this list here, you can see that these are the most common things that are actually contributing to frailty and sarcopenia. And yet they are things that for which we do not have medical treatment, if you think of medical treatment as drugs, but we certainly do have treatment in the form of exercise, nutrition, and other things. So the Asia Pacific guidelines are really quite clear on what is the appropriate management of frailty. I'm not going to go into all of the evidence behind this consensus statement, which I think many people would be familiar with, but I would like to point out is that there is a very clear recognition in this consensus statement that strength has something to do with frailty or the lack thereof, that there is this overlap between sarcopenia and frailty, which means that a lot of what we would do to treat one condition is also appropriate for the other, that resistance training or anabolic exercise, because of this focus on strength and changes in strength, becomes very, very central to the treatment of this condition and to preventing its progression. So this very core feature of sarcopenia is really inseparable from most definitions of frailty. And based on those key aspects, the management recommendations really focus on a progressive individualized activity program that must contain a resistance training aspect. So there might be other elements of exercise that are needed, for example, balance training in some people, but you really can't eliminate this core aspect of resistance training from the management of frailty. So rather than go through all of the evidence, which is what I would normally do in these talks about why we've come to these consensus opinions, what I thought I would do is actually present 4 different case studies in frailty to really bring home how actually this looks, how real this is in practice when you put these consensus guidelines to work. And hopefully at the end, next time you see an older person with a stick, you may have this image in mind rather than the former one. So I'm going to begin with a typical patient with accumulated deficits, which would be corresponding to Ken Rockwood's definition of frailty as the accumulation of lots of different conditions. So this is an 87-year-old gentleman, widower, who lost his wife to Alzheimer's disease, had polio, and then developed post-polio syndrome, strokes, depression, AFib, aortic valve replacement, cardiac arrest with pacemaker, prostate disease, bladder cancer, arthritis, hernias, bowel obstruction with surgical repair, and rotator cuff disease. So when you think of a man like this, he's pretty much the opposite of what Jack Rowe would have called successful aging at Harvard, which means that you age without disease, with high levels of cognitive and physical function and high levels of engagement. So this gentleman obviously has not aged successfully. Well, here he is, Mr. Ray Moon. You can see his little pacemaker muscle right here. The world's oldest competitive bodybuilder. Very sadly, our friend Ray died last year at the age of 90. But he is an example of someone who has accumulated lots and lots of deficits over the course of his lifespan. But in fact, he took up bodybuilding exercise at the age of about 75 and really never looked back after that point. We've written up his case recently for a journal. And what is really remarkable about Ray is that what he did with his lifestyle to overcome all of these challenges and medical conditions that he accumulated was to change his sarcopenia, to change his muscle strength and his muscle mass in a way that was quite distinct from most people of his age. And this is one of the times we brought him into our lab. We measured his muscle strength, and he actually had a muscle leg press strength, which was equivalent to that of would have been predicted for about a 25-year-old male or 20-year-old male, the second highest, strongest person that we had tested in our laboratory at the time. So certainly not what you would think of with somebody with those number of chronic diseases. And perhaps even more remarkable, if you look at his body composition, he was pretty much at the 95th percentile of fat-free mass and down at about the 2nd percentile of fat mass, again, for, excuse me, older, or for adults across any age, actually. So his lifestyle had actually changed the trajectory of his body composition and his strength in a way that would not be predicted from just looking at his medical history. So is he frail? According to Ken Rockwood, yes, but really he is robust despite this accumulation of deficits, and despite having aged unsuccessfully, his lifestyle has actually made him somewhat quite different than that. The next case I'd like to talk about is somebody who is pre-frail. And again, pre-frailty has many different definitions. If you go by John Morley's simple frail scale here, 1 or 2 points on this scale, which you would be familiar with, is enough to get you into the pre-frail category. So this is Sylvia. This picture of her was taken just 2 weeks before her 96th birthday, a couple of months ago. Lives alone in a home in Balmain. Her medical history, like Ray's, is quite complex. Unlike Ray, she has sarcopenic obesity, but also osteoporosis, arthritis, has had bilateral knee replacements, COPD, bronchiectasis, rotator cuff tears, nephrectomy with chronic kidney failure, and CAD with stable angina. So that's Sylvia. And by the frail scale, she would be pre-frail going by this. She's not limited in terms of her walking or her stair climbing, hasn't lost weight, but she's accumulated enough diseases to actually put her into that category. So luckily, Sylvia ran into this exercise physiologist, Nathan DeVos, at Balmain Hospital 11 years ago, and took up weightlifting exercise, very similar to Ray, high intensity weightlifting exercise, which she has practiced faithfully over the last 11 years. And you would know that muscle mass is something that declines with age quite predictably. About 50% of your muscle mass would be lost over the lifespan. And this is an anatomical study done by Lexel many years ago. This is Sylvia's lean body mass measured over the last 11 years at Balmain Hospital. And you can see that she's lost no lean body mass over that time, despite aging from 85 to 96 years of age during that time. And certainly, again, changing that trajectory of what we would consider to be normal aging, if you will, in terms of her lean body mass. And again, the other component of sarcopenia that we're interested in, probably even more interested in than muscle mass, would be muscle strength and power. And again, as you know from the Baltimore longitudinal study on aging, women in particular lose about 75% of their muscle power by age 75 and about 50% of their muscle strength. Again, that would be what would be expected, and would decline even further between the ages of 85 and 95, as Sylvia did. However, Sylvia, training for 11 years at the Center for Strong Medicine, bar a 7-month period in 2020 when she was interrupted by COVID. And what you see it here are her strength gains, and she's gained, you can see, up to over 100% in leg press strength and slightly less in upper body strength, despite aging over this 10-year period. And here's COVID closing down the clinic. And you can see that in this very short period of time, 7 months, she really lost not all, but most of the gains that she had made over the previous 10 years. But as soon as she started retraining, she's now on the way back to her strength gains again. Excuse me. So this is an example of somebody with pre-frailty who has, again, averted the typical trajectory of losses of muscle mass and muscle strength by this very particular kind of exercise that she's taken up over this time, which she is very, very faithful in conducting. So I'm just going to give you, you might wonder what it actually looks like to lift heavy weights at age 96, and you might not believe that she can do it. That we did measure her strength, her peak strength, a couple of months ago, and then we asked her to lift 80% of that 8 times, which is a typical training regimen that we would use for sarcopenia. And here's what that looks like.
What we're going to do now, Sylvia, is a set at 80% of that load, and I'll ask you to do 8 repetitions in succession. So you can place your feet back up on the foot plates. Good. And in the same fashion, Sylvia, just breathing out as you're pushing up and breathing in as you're coming down. I'll just change that weight back. All right, so when you're ready, Sylvia, big deep breath in, breathing out as you push, breathing out, big push out hard. Good, 1, slowly back, good control, that's good. Breathe out, 2, good. Breathing out. Again, 4. Good, good control. All right, so pushing out again there, Sylv. Good. And slowly back. Good. And again, breathing out as you push. 7, good. 1 last one. 8, good. Slowly back, Sylv. Good work. How did that feel? Great.
So what you've actually seen there is a typical way that we train people at 80%. We don't actually water down the intensity of weightlifting exercise for people because they are pre-frail or frail, which is, I think, why Sylvia has been able to maintain and show the gains that she has. But that's all it takes. That's 1 set of exercise. So if you multiply that by 6 or 8 different exercise muscle groups, that would be a training session that would be very typical for all of our patients, actually. The next category of individual I want to talk about are people who have already become frail. And obviously, this is something which is very common in clinical practice. And hip fracture is an example of a condition which is a common sequelae of frailty. And you can see that particularly the shrinkage of lean body mass, the loss of muscle and bone is one of the most important risk factors for hip fracture. Hip fracture, I think, is the geriatrician's dream, if you will, in terms of the kind of condition that we were actually trained to treat. The problem with hip fracture is that it's very, lots of different people are involved in the care of people with hip fracture, and depending on what your particular discipline is, hip fractures may look quite different to you, and what you do is really analogous, is really very closely linked to how you see the problem. So for an orthopedic surgeon, this is what a hip fracture looks like. And so the solution to this is obviously to fix the broken bone or replace the hip, and then all should be fine. However, to a geriatrician, this is really what a hip fracture looks like. It looks like a bone that's broken inside of a body that is frail. And so the treatment becomes really very, very different than the treatment of an orthopedic surgeon. And when we looked at the literature a few years ago to see what was it that predicted poor outcomes after hip fracture, it turned out that all of these factors, which are very much a syndrome of frailty, were the things that predicted poor outcomes after hip fracture. Nothing to do with the timing of the surgery or the type of surgery, but really all of these other features of frailty. So we designed a study a few years ago to look at what would happen if we actually treated hip fracture as though it was frailty, and actually dealt with all of those other kinds of factors that are part of the problem. And this is little Annie Nyman, who again lived in Balmain. At the time, she was 90 when she broke her hip, lived alone with her cat, and she joined our study because she was intent on being able to walk to the corner store and buy cat food for her cat every day, which is what she did. And she was afraid that she wasn't going to be able to do that again after her hip fracture. So the HipFit study was centered around high intensity weightlifting exercise, exactly what you saw Sylvia just doing in that video, using these muscle groups that are quite important for function and transferring, et cetera. But in addition, we treated other components of frailty if they were needed. So particularly in hip fracture, things like malnutrition, polypharmacy, sometimes depression and cognitive impairment become quite important. So everyone got weightlifting and balance training. And then if they needed it, they got some of these other interventions. And on average, it turned out that this cohort of people with hip fracture from Royal Prince Alfred Hospital needed about 10 of these 13 different things treated in order to optimize their function after the hip fracture surgery. And what we saw was that quite remarkably, we reduced what's called poor outcome, which means either you're dead or you're in a nursing home. Either one is considered poor outcome, by about 85% compared to usual care in the tertiary care hospital at Royal Prince Alfred, and followed by physio, et cetera. So what that meant was that what we're typically doing with hip fracture, and to this day, what we typically do to treat hip fracture is treat it like it's a broken bone. Make sure people don't get delirious around the operation, but we don't really give them treatment for the frailty syndrome that is really what caused the fracture in the first place. So I think this is one of the most important conditions of frailty for which anabolic exercise is really core to adequate recovery. And I'd like to move now to the final case, which is somebody with very severe frailty and disability. And again, talk about the use of anabolic exercise. So when we began 34 years ago treating sarcopenia, we actually began in a nursing home. We actually began with people with very severe frailty and disability. And what we saw was that if you gave them high intensity weightlifting exercise, whether or not you combined it with nutrition, in fact, you got very, very robust adaptation of the skeletal muscle, including myoblast formation, myotubes, and increase in IGF-1 by huge amounts after weightlifting exercise for only a few weeks. And these people who were between the ages of 85 and 103 in a nursing home. So there didn't seem to be an age at which the response to anabolic exercise was actually blunted in this case. And unfortunately, I would have to say that we did that first study in 1990. So now we're 31 years after that. And what we see in nursing homes very typically are very similar kinds of problems with frailty that's going untreated. And this is a case of Max and his wife, Lisa, a gentleman with Lewy body dementia who joined one of our studies a couple of years ago. Max had relatively severe Lewy body disease, along with COPD, osteoporosis, and sarcopenia. He lived in a nursing home with his wife, visiting daily, recurrent falls, which unfortunately the response to the recurrent falls led him to be actually hospitalized with delirium. And then because he lost weight and stopped eating after that, he really was very unstable on his feet, and he was restrained to his chair for almost all of the day, and had lost probably 20% of his body weight in just a few months since these falls, on a pureed diet and not eating very much. So that was the history when we saw him. The medications that he was on, you can see the list here, lots of different medications, many of which would be on Beer's list of relatively inappropriate medications for older adults, but again, not atypical for nursing home residents. And what we saw in Max was that this combination of malnutrition, immobility, polypharmacy, sarcopenia, superimposed on his Lewy body dementia, was really what the issue was, and not really the Lewy body dementia as much as all of those other things. And unless they were all targeted, we would not be able to optimize his function. I'll just show you a snippet of what he looked like when we first began to treat him. This is at a time when he was still relatively restrained most of the time in the chair and on lots of medications. And he and his wife wanted us to use this video to help healthcare professionals.
Messi, sitting up tall for me. That's better.
Yeah, that's better. Yeah.
So you can see there that he is quite sedated. He is able to respond when people ask him to do things, however, but the conditions in which he was left in the nursing home were really left him unable to actually improve from his medical illnesses. So when we saw him, the first thing I did was look at his medications, as a good geriatrician would, and found that probably he didn't need any of them. And we were able to recommend to the GP to discontinue pretty much all of them, except for the valproate was the one that was not stopped. All of them were discontinued, bar that one, and no ill effects were reported from discontinuing these medications. And we didn't actually discontinue them one by one and see what happened. We actually discontinued them all at once. And the only thing we added was vitamin D, which it looked like he needed. And so following our intervention, he was actually left just on sodium valproate and then PRN albuterol inhaler. So that was the deprescribing. The exercise treatment that we used for Max was initially in the nursing home because he couldn't actually transfer into a car or get out of the nursing home at the time. And what we did was give him weightlifting exercises in the nursing home with leg weights and some upper body training as well, until he was able to actually stand independently enough to transfer into a car, at which point we then had him come to our clinic so that he could do high intensity weightlifting exercise, the kind that you saw Sylvia do, to really advance him quite a bit more than could be done in the nursing home. So this is what he looked like when he first came into our clinic after 4 weeks of nursing home exercise.
There you go. Use your handle there, okay? And there you go, you found it. There you go. Lean forward for us. Ready? You get the ready. Lean forward. 1, 2, 3. Go, 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 go. Good. Nice. Okay. Good to feel it. Yeah, take the chair away. Let's go, Maxie. Let's walk around the clinic.
So you can see there that he was now able to almost stand up unassisted, which prior to the 4 weeks of exercise in the nursing home, he actually couldn't do at all. And I'm just going to
do a sharp right.
Advance this a little bit here because I want to show you what happens when we now put him on the leg press machine.
Give it a go. We're actually going to push the machine out. I think what we might do, we might move you forward. Looks like you're going to walk back. We're going to move forward a bit, Max. Okay, I'm going to give you a bit of a shuffle up, okay? 1, 2, 3. There you go. There you go.
The plates so that
Just going to advance this a little bit more.
Hold there. Try and lift your bottom. 1, 2, 3. There you go. Yep, put it up the chair. There you go.
So you can see how difficult it is to get him on the leg press machine, which is why.
There we go, Max. Now we're in a position. Okay. You were moving this quite easy before. Are you comfortable there? Yeah. Any pain? Good. What like to hear? What's it on? That's 200. Hold that here nice and tight for us. Now, Max, what we're going to do is like when you're pushing Lisa across in the shed. Okay? You're going to push these out. Not just yet. These are going to move. See these move? Okay? Yeah, come back in. Too easy for you. Okay? Now, what I want you to do, get your breath back. Before we push, you're going to take a deep breath in. And as you push, you're going to blow your feet away as you push, okay? Can you take a deep breath in for me? Deep breath in, Maxie. Breathing out and pushing out. Blow away, good. Come back in, nice and slow, nice and come back in. Let it come back in, Maxie. Relax your legs back. Yeah, there you go. Deep breath in for us.
Okay, so you can see that later. I'll share the slides as longer video, but what you see is that it obviously takes a lot longer to get Max onto the machine, to give him the instructions that you need to give him, but he's actually able to do the exact same exercise that somebody who's less frail can do, but with a lot more coaching and instruction to do it. We also trained him for power, which I won't show you this one just for lack of time, but the exact same movement, but done as fast as he can do it, which is one of the important kinds of exercise to do for Lewy body dementia and Parkinson's disease, but also has benefits for bone density as well.
Deep breath in, Maxie. Deep breath in. Breathing out and push, 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 push. Good. Come back in, Max. Come all the way back in.
So again, he's using a weight that is relatively heavy for him. Again, about 80% of his maximum strength. And I'll just show you this last video here.
1, 2, 3, up. Standing up tall.
So there he is, independently standing after 8 weeks of exercise.
Now I'm gonna walk with you. I'm gonna keep the walker out front. Okay, keep walking. Yeah. Great, not using the walker.
That's amazing.
Keep going. The walker's there if we need it, but we're gonna keep walking just normally first, okay? Can you wave to the camera? Wave for Trini? Yeah. Go ahead, wave for Trini.
Cool way.
And push your head forward, ready?
So, so that's just to give you a little snippet of what it looks like to train somebody who's very, very difficult to train, with very severe frailty, malnutrition, polypharmacy, et cetera. But it is possible to go through this sequence from being really strapped to a chair, sedated most of the day, unable to stand up by himself, to actually ambulating independently with some contact guarding. And what we saw in Max was that this very close interaction of his weight loss, his deconditioning, his sarcopenia, and his frailty, and you can see, and even his cognition. And you can see here as his body weight went down with all of the falls and hospitalizations and recurrent illness, his skeletal muscle mass went down, his mini mental score went down, his SPPB score went down to 0. The green bit here is when we trained him for the study for the 8 weeks. And you can see that everything improves in concert. His body weight, his skeletal muscle index, his mini mental score, and even his SPPB. So none of these things are able to be separated from each other. And that's why the treatment of frailty and sarcopenia needs to be this holistic, and as the consensus statement suggests, always looking for the interaction of malnutrition and polypharmacy and sarcopenia together as the best way to mitigate frailty. So the recommendation about the resistance training program is clear. What I think is probably not appreciated as much as it should be is that there is a sequence to the kind of exercise that needs to be prescribed for frailty. And if somebody can't stand up from a chair like Max, there's no point trying to get him to walk or even to do balance training. So it's resistance training to get to stand up, balance training to stay up, and then aerobic training in order to mobilize and ambulate a little bit better. But that sequence is really critical. Flexibility exercise has really no real role in this kind of condition. You will get more flexible as you do these other kinds of exercises. Walking, again, is something that should be reserved for people who have enough strength and balance to walk. So it shouldn't be the first thing you think about. It should actually be the last thing you think about. And I think, unfortunately, in terms of clinical practice, the sequence is often exactly the opposite. We try and walk people who don't have the strength and the balance to support their body weight, which is why falls occur. So putting that on its head is really the way to do it. And the treatment that's recommended for frailty is actually no different than the exercise treatment that's recommended for healthy older adults by the ACSM, American Heart Association. So a couple of days a week, high intensity, progressing major muscle groups, similar for the Strength and Conditioning Association. The kinds of exercise that's recommended is exactly the same. And I think this is the point that really needs to be driven home, is that there is no change in prescription just because you are robust versus very frail. So what we did with Max is exactly what Ray Moon was doing. And that's the reason that the muscles respond, is that the treatment is actually exactly the same. So I think that's what's important. The problem with resistance training is that no one does it. So in the community, about 10% of older adults in Australia currently do some kind of weightlifting exercise, probably low intensity. 90% don't do any. And if you move that to people who are frail like Max, it's close to 0. So the problem is that we're not actually doing it. And when we do use exercise, we're not actually using it as medicine. So if exercise is medicine, then we need to be using it for things that we don't have any other medical treatment, like frailty and sarcopenia, perhaps substitute for more hazardous forms of treatment, like antidepressants for depression, for example. We might want to augment other kinds of treatment strategies for lung disease or heart disease, offset side effects of current treatments. For example, ones that cause orthostatic hypotension or sarcopenia, and most importantly, counteracting these age-related changes in physiology, the loss of muscle mass and muscle strength, which are predictors of morbidity and mortality. And when you look at the resistance training prescription in terms of the evidence base, it's absolutely crystal clear that intensity is the thing that matters. It's not about volume. It's not about anything else. It's about intensity. So since 1990 or 1988, we've been training people at this hard zone of intensity, because that's what works optimally, not just for sarcopenia, but also for depression, for cognition, for diabetes, for heart disease, for osteoporosis, for almost any condition you can think of. So intensity is absolutely key. Meta-analyses, which you can read about, also suggest that the higher intensities work better in terms of these kinds of outcomes. High is better than moderate, high is better than low intensity. So really there's no time or no condition for which you can think about where you would actually want to use a prescription that is not that intense. It doesn't take months to get up to that intensity. This is from our brain study, where over 5 sessions, we get from 50 to 80% of the 1RM. And you can see that the strength gains are actually quite almost linear in this first period of training. And so that's the kind of gains that you will get if you actually train people at the appropriate intensity. Unfortunately, what happens in the community are things like this, which are called strength training, but actually aren't. And I think this does quite a disservice to people that are in our care. You can train people at home without bringing them to a clinic or a gym. And this is a meta-analysis of home-based trials. However, it's quite clear that the gains that you get at home are not quite as good, or often not nearly as good as the ones that you can get in clinic. So if there is an opportunity to bring somebody to a gym or a clinic, certainly better to do that. Supervision is also a very important component, whether that's remote or face-to-face supervision for these kinds of interventions. We do have materials which you can download yourself and use for home-based training. It is possible to do it at home, but in my experience, it's actually much more difficult to get very good gains at home compared to what you can get in a clinic. And unfortunately, again, in New South Wales, we don't have a lot of good programs in the community. If you look up what kind of programs are available, and I've just clicked on gentle exercise here, I can find lots of gentle exercise classes available. But as you can see here, there isn't a single strength training class even listed on this website for active and healthy aging. So that's not correct. That's not good enough. The literature would suggest that we need to do much better than that if we really want to address frailty and sarcopenia. And I think it's not just in Australia, but internationally, there still is a reluctance to use high quality evidence-based exercise. 2 very big, important studies, which are both negative, were published in the last couple of years. The STRIDE study, which said it was about strength training, but if you look at what they did, it's standing up from a chair and minor little squats. And it didn't work. It didn't prevent falls or have other kinds of benefits for these older adults. And the reason it probably didn't is because the exercise was actually not evidence-based. Another study, which was just published, called Do Health, again, calls itself strength training. But when you look at what they did, it was, again, sit to stand, a one-legged stance, and some elastic bands, none of which were progressed to higher intensities of training. And again, this study had no positive outcomes in terms of function, hypertension, cognition, falls, quality of life, or functional performance. You can read the letters to the editor, which were written about this study, saying that, you know, it should not have even been published and called strength training because it actually wasn't strength training. So I think there's a lot of bad medicine going on when it comes to exercise, unfortunately. And the older the cohort, the frailer the cohort, the more likely it is that they're not getting proper exercise. It is possible to incorporate robust exercise into any setting. You should know how to do it in healthcare settings in a way that is evidence-based by utilizing only programs that have been shown to work, which does not include gentle exercise, providing support, using caregivers as exercise buddies, etc. It is possible to do it in the acute care hospital. This is a study from Spain where they had older men and women doing power training in the hospital when they were hospitalized for pneumonia, etc., and showed better outcomes in terms of cognition and function. This is our nursing home in Townsville, where we just set up our Kaiser machines in a nursing home where we'll be treating frailty with robust exercise, malnutritional assessment and treatment, and deprescribing as a way to actually improve frailty and cognitive impairment in the nursing home. So it is possible to do it, but the way that the healthcare system works now, we don't pay for it. We don't outfit nursing homes so they can actually provide frailty treatment that's needed. And so we're really underserving our cohort, I think, quite substantially. So frailty, just to end up, is not inevitable or untreatable. And rather than being a barrier to robust exercise, particularly weightlifting exercise, I would say it's the most important reason to prescribe weightlifting exercise. You may not end up looking like Ernestine Shepherd here, but you certainly may look like Max did when he's able to stand up from a chair. And if that didn't bring a tear to your eye, then I would say you're probably not a geriatrician. So I think what we really need to do is have a paradigm shift where we think about these modifiable frailty components as particularly depression, sarcopenia, isolation, loneliness, malnutrition as primary, rather than focusing on the number of diseases someone has and the kinds of medicines that we're using to treat those diseases. Treating all of these other things, which don't have drugs as their treatment paradigm, is really what we need to make people's quality of life better. Annie Nyman knew it. That's why she signed up for our study after breaking her hip at age 90. And I think now it's time to convince healthcare professionals that they also need to do this. We're not going to stop aging. We're not going to prevent people from ever reaching this disability threshold, but hopefully we can slow down that trajectory, attenuate the risk of disability to some degree. So thank you for your attention. And as always, I dedicate this to our very first volunteer, Helene Freundlich in Boston. Thank you.
Thank you so much, Maria. What a wonderful talk, and so many examples. This also led to a couple of questions already in the chat, and really feel free to put more in that, and we will also try to unmute individuals. And I would like to first give the floor if Professor Itamar Levinger would like to ask the question himself. Otherwise, I will read it out. Itamar, are you here? Can you unmute yourself?
Yes, thank you. Great presentation, Maria.
Thank you.
Just a quick question. Yes, so you published a very nice paper in 1994, so almost 30 years ago, let's say, about the benefits of progressive resistant training for frailty and older adults. So in the last studies, we have a lot of evidence in regard to the effectiveness of progressive resistant training, but from some reason you just said today that only 10% performing it in the community. So what do you think is our main problem in the implementation of resistant training in the community? Because I know that a lot of people trying to have more evidence and more evidence, which probably we don't need anymore. We probably need to think of how to implement that. So I just wonder, what is your opinion about this?
Well, I mean, I think to me, the main problem is that it's not considered medicine by physicians, for sure, except for a few geriatricians. And so it's not something that is recommended to patients who have diseases that are very clearly responsive to resistance training, things like congestive heart failure, COPD, renal failure, depression. And because it isn't recognized as medicine or paid for by, Medicare or health funds, it's not in the mainstream. It's still considered to be an optional adjunct. So I think that we really need to have policy changes that actually will put it in the realm of other kinds of medical treatment, because that's what it is. It's clearly that's what it is. I don't think the barrier is really so much on the side of the consumer. I think most of the time, if you ask somebody, would you like to stand up by yourself from a chair, that's what they want. They will say yes. And if you say, I have a drug that will do that for you, it's called weightlifting, they will take it. The people who are mostly reticent, and particularly reticent to do it at high effective intensities, are healthcare professionals, physiotherapists, physicians, nurses, et cetera. So I think education is key to actually overcoming that barrier.
Okay, thanks. And another question leading up to that is from Dr. Logan, who asks, and please speak up if you're here, who is responsible to do the training, and could an exercise physiologist do training session and design programs for community dwelling individuals? Who's in charge? Oh, I see.
Yes, so I mean, I think exercise physiologists definitely can do it. Physiotherapists can do it. In my experience, I have trained pretty much every profession dietitians, social workers, occupational therapists, nurses, et cetera. And actually, in my experience, the people who come with a medical background, who understand geriatrics and understand medicine and frailty, and to that you add the exercise knowledge, they're a lot easier to train than people who have no medical knowledge whatsoever or very little, and have only exercise knowledge. So I think there is no real single discipline that needs to do it, that needs to be able to do it. I think to get it to be broadly accepted, I think we have to train lots of different professions to be able to do it. The best trainer I ever had in Boston was a recreational therapist who had no background, but was able to understand frailty in older adults and how to do it properly.
Good, thank you. And another question is about, I would say, especially a situation in the clinical setting in hospital where the terminology medical clearance needs to be done before starting resistance exercise training. The question is, do we need medical clearance, and what should that entail to start training?
Right. So medical clearance, I think, is a little bit controversial, I would say. The idea basically is that there are a few things that you need to look for in somebody before you start weightlifting exercise. And particularly that's around joint abnormalities. So rotator cuff tears, unstable, medial meniscus of the knee, et cetera. But in terms of a cardiovascular risk screen, that kind of medical clearance, we typically don't do that in clinical practice, and we don't do it in most of our clinical trials either. And it actually isn't recommended to do stress testing, for example, before weightlifting exercise. So I think the thing that you do need to do is basically somebody needs to look at the person in terms of their joints, and that could be a physician, it could be a physiotherapist, it could be an exercise physiologist, and make sure that at the moment things are relatively stable. Obviously, arthritis is going to be there in most of the people that we train. It's not a contraindication to strength training, but you need to know what causes pain. There may be certain movements that you need to do differently, or things that you need to avoid in somebody who's got an acute rotator cuff tear, et cetera. But certainly the kind of high-end medical screening that would be sending somebody to a cardiologist for a stress test, none of that is actually necessary. And there's very little evidence that resistance training causes cardiovascular adverse events. In fact, it's safer than aerobic exercise in terms of cardiovascular events, because it doesn't have the same effect on the double product as aerobic exercise does. So we certainly look for unstable musculoskeletal conditions, but that's about it.
Okay. And that leads a little bit to the question of Kara, talking about knee arthritis and what kind of exercises with weights are suitable.
Yep. So there are lots of studies on arthritis with weightlifting exercise, and if you look at the current position stand of the RICGP, the exercise that's recommended is land-based strength training as the #1 kind of exercise to do for arthritis. So weightlifting exercise decreases pain and increases function in arthritis. If somebody has a very inflamed joint to start with, we sometimes start with isometric exercise, and then as they're able to move the joint partway through the range of motion, we would add dynamic exercise to the point of pain. And very typically, if you strengthen the muscles and tendons around a knee joint, the pain will decrease, the stability of the joint will increase, mobility will get better. And so it actually is a appropriate treatment for knee arthritis. There's some evidence that you might be able to improve outcomes after knee replacement surgery by prehabbing people with strength training before the surgery. And that kind of evidence, we need more of it, but there is some preliminary evidence that that's the case.
Okay, perfect. Thanks. Tracy asks if you found the treatments, and I think she's referring to the resistance exercise ones, beneficial also in managing Parkinson's disease.
Yeah, so we've done a study on Lewy body dementia, and it was definitely, and actually a combination of Lewy body dementia and Parkinson's disease dementia, and it definitely helps with mobility and strength. Whether or not you can improve Parkinsonian symptoms is a little bit less clear from the literature. And I think, that's something that longer studies need to look at. There's certainly some animal data that suggests that actually the changes in the brain would be quite helpful for both Lewy body dementia as well as Parkinson's disease. But certainly, if you look just at mobility, like you saw Max able to, get up out of a chair by himself, that those sorts of outcomes are very predictably improved with weightlifting exercise, as well as obviously balance training is clearly critical. And then once somebody is able to walk, some kind of mobility training, gait training to kind of improve the smoothness of the gait if possible.
Okay, perfect. I have one more question in the chat. If somebody else has a question, please raise your hand. There is a reaction symbol. You can do that there. There is a question of Christopher Oliver, and I think he's puzzled, as lots of us are, how to measure body composition. Should we use a BAA or a DEXA or an MRI or calf circumference? So what do you do, and what you prefer that we are doing in clinical practice?
Right. So obviously clinical practice is different than research. In research, you clearly would be looking at MRI or CT or creatinine, D3 creatinine dilution, I think, as a very good estimate of direct estimate of muscle mass. In clinical practice, you're not going to have access to any of that. And the thing that I would not do is DEXA scans, even though that is available in clinical practice. There's very good evidence now comparing it to D3 creatine excretion that it overestimates muscle mass by a lot. And it actually, the DEXA measurement of lean body mass, which includes organs, et cetera, skin, or even the appendicular skeletal muscle mass from DEXA, vastly overrates how much skeletal muscle is there. And it doesn't predict incident disability or other poor outcomes. So I wouldn't use DEXA. If you have a BAA, that's what I showed you with Sylvia, not a bad measure, plus or minus 3 or 4% in terms of reproducibility. If you do it fasting in the morning at the same time of day, et cetera, it's pretty good. Calf circumference is an interesting measure that we're starting to look at. And there is some evidence that calf circumference is actually pretty closely related to whole body creatine excretion. And it's something that, nicely enough, you could actually do remotely. You could show people how to do it over Zoom and have them do it for you without even seeing them. So compared to any other body composition technique, all of which require you to see the person face to face, calf circumference is probably the only one that you could actually do remotely. And we're doing or proposing a study right now where we would actually do that in a large number of people who can't come into clinic. So I think certainly, and calf circumference, as you know, is part of the M&A. So it's always been part of nutritional assessment because it is, potentially an index of muscle mass. So I would say clinically using calf circumference or BIA, research-wise, moving to the more definitive measures if you can get them.
Okay, perfect. Thanks so much. I recognize the one hand from Andrea, but if you want to unmute, please do so, but I don't see the hand anymore. So maybe that was just a tryout. So if not, then Maria, thank you so much for your wonderful talk. We really learned a lot how to possibly get the percentage of 10% a little bit up that we implement things in clinical practice, and I would really encourage everybody to do so. So thank you very much.
Thank you.
The next speaker today is Professor Gordon Lynch. I haven't recognized him yet in the panel. Hopefully he's here. And I see lots of clapping hands, virtual. So thank you a lot. Gordon, are you here?
I can see him listed as a participant.
We can't hear you, Gordon. I can see you, but we can't hear you.
Okay, and I will introduce Gordon in the meanwhile. Professor Lynch is director of the Center for Muscle Research at the University of Melbourne in the Department of Physiology, where I met him. And he is a wonderful, internationally renowned researcher studying muscle growth and adaptation, plasticity, and therewith really contributes to the understanding of muscle wasting and different conditions from young to old, and genetic diseases to sarcopenia and muscle weakness. And he will talk about the future of, hopefully he will talk about the future of muscle health, and then beyond physical activity and nutrition.
I'm just concerned if you can't hear me. Is that better?
That's absolutely, you're perfectly, we're seeing you perfectly and we're hearing you perfectly. And thank you for your time being here. And once again, if you have any questions, please use the chat box, and otherwise I will also, you can unmute yourself if you have any questions afterwards.
Okay.
Gordon, the floor is yours.
Thank you very much, Andrea. And it's actually it's a privilege to be part of this effective special presentation. And I think based upon the audience participation, it's really important that we have this comparison between the clinical applications and also the basic research. So my talk will be focused more about the muscle per se, and hopefully what we can do to preserve it, especially during aging. And I thought I'd start with some of the questions that have actually been touched on already by Maria earlier on. And to ask the questions regarding...
Gordon, we can see your slides, but it's not on slide mode. I think maybe you have two computer screens.
No, I don't.
We see all slides, but not one.
If you just click on slideshow, Gordon, at the top.
How's that?
No.
Oh.
Maybe you can unshare and then share again. That most of the time helps. Yep. And then slideshow.
Slideshow.
I'm on slideshow and it's not coming through. I don't know. This is this one.
Yep.
How about that? That's on slideshow from the top.
No.
Just click on that.
I'm seeing it very clearly on my laptop, but I can't see it coming through for you, obviously.
So maybe what you can do is just send it to me, and I will share the screen.
Or instead of sharing the PowerPoint, Gordon, you can just try and share your actual screen, and then it should show what you're seeing on your screen.
How about that?
Yep. Perfect.
Okay. Let's see how that goes. So this was where I think where I was, except I can't advance the slides. There we go. Okay. So the questions I wanted to ask from the outset were these changes in muscle health inevitable? Is it just going to happen regardless of what we do? Are they immutable? Potentially, can they be changed? And that could also mean, can they be reversed? And the last question relates to whether they can be attenuated. I think we can see very clearly from Maria's presentation that certainly in terms of the exercise interventions and nutrition interventions, we can slow the rate at which these changes occur. So there's been a lot of evidence since the late 1980s in terms of the benefits of strength training as the key part of an exercise prescription for healthy aging that Maria so eloquently described previously. And in conjunction with the strength training, there's also the nutritional interventions that we've seen over the last 30 years or so, the emphasis on protein needs for the elderly, the benefits potentially for elements of the Mediterranean diet, and also some emerging approaches too in terms of nutritional interventions that can potentially slow the rate which muscle wastes with age. So in terms of whether muscle effects, the effects of aging on muscle are inevitable, I think, you know, even if we do all the right things, is it possible that these things will still occur? And I sort of take you through the evidence from physical activity, especially the effect of aging on physical performance, both in terms of running and also comparing that with weightlifting exercise. So with running, whether it be sprint performance or whether it be marathon performance, this is age on this axis, this is speed on this axis here. What we can see with increasing age is that we simply don't perform the same as we did when we were younger. As we age, in terms of sprint and with marathon performance, our performance levels off. Now, these aren't sedentary people asked to perform these activities. These are masters level athletes who train and compete for a large proportion of their lifespan. And if we look at on this axis here, this is that what masters level weightlifting, a more explosive type of activity. The drop-off is even greater in terms of performance as a function of age. We simply don't perform the same way we did when we were younger. And even those that are genetically gifted and those that are selected for excellence in those particular sports, it's very clear that as they get older, they're not able to perform the same way they did when they were younger. However, I think it's very clear from these sorts of highly active individuals that have maintained the best possible interventions for aging, that they're the ones that we expect to have a slowed trajectory in terms of what will happen in terms of the effects of aging on muscle mass, in terms of the effects of aging on muscle function. And the idea is that if we maintain these activities, our capacity for independent living and health span will be promoted. And perhaps one of the most often used slides in gerontology is Dr. John Turner at the age of 67, a devotee of resistance training and often celebrated by his physique, which is quite enviable, as you can see. Clearly, an enviable physique and someone who's not going to be wanting in terms of needs to perform the tasks of daily living. And if we advance in terms of 12 years of maintaining that activity pattern, resistance training as the preferred and key intervention to preserve muscle health, you can see that at the age of 79, Dr. Turner is still in pretty impressive shape. We've even given him a heavier set of dumbbells to pose with to indicate that he's been doing pretty well over that time. But that's not the point of what I wanted to show you. When we put them side by side from 67 to 79 years of age, still maintaining the best possible intervention to preserve muscle health, you can see very clearly there is still some decline in muscle mass, and if we would think the quality of that muscle over that period. Now, that's not to say that he wouldn't be a candidate for independent living. It's quite clear that he would be. But the purpose from a muscle perspective is to show that even with the best possible intervention, there is a decline in muscle properties as a function of age. So the question is, of course, why is this happening? Why is John Turner, who's doing the best possible intervention and looking pretty good at it, still not able to maintain the same level of muscle mass he did when he was younger? And this is another often used slide to show how muscle homeostasis, in this case it's about the preservation of muscle mass as a balance between the synthesis of protein and the degradation of protein, that there are multiple interventions or multiple factors that contribute to this homeostasis. And that even if we do the best to, and as was described by Maria in the previous presentation, in terms of exercise, bias towards resistance training and the best nutrition we can think of, there are still multiple other factors that could be influencing this balance between synthesis and degradation of protein that ultimately will be about the preservation of mass or the loss of mass. And that could be the levels of circulating hormones, it could be genetic factors in terms of fiber distribution, It could be about the maintenance of an electrical signal between the nerve and the muscle. It could be inflammatory factors, which we know are part and parcel of many different conditions associated with aging. Blood flow could be a factor, the existence of other diseases, etc., could all be part of the equation. So we need to consider that even if we do these two top interventions, exercise and nutrition as interventions, we may not still be able to maintain muscle mass. Now, I've depicted it here in terms of these inputs into this bucket. The holes in the bucket in terms of the preservation of muscle can be influenced by many different factors, and they include inflammation and overcoming this systemic inflammation that may lead to an anabolic resistance despite these interventions. It could be because of these deficiencies in circulating anabolic hormones that are essential for maintaining muscle mass. It could be about this loss of electrical connectivity between the nerve and the muscle, particularly it could be intermittent or long-term deficits in terms of the patency of those connections at the neuromuscular junction. And another one, which is sort of less well known and less well described, is a loss of integrity of the dystrophin glycoprotein complex, a series of proteins at the muscle membrane, which are known to be very important for the transmission of force, but also critical for muscle signaling, in particular the signals required to maintain muscle mass and to confer adaptations to interventions. So if we go back to our running theme of the questions about whether we can offset these effects of aging on muscle health and think outside the square in terms of what interventions may be possible, theoretically possible, and eventually realistically possible. Me and many others have reviewed all of the interventions over many years, thinking about, in particular, hormonal interventions. It could be about hormones directly. It could be about growth factors like insulin, like growth factor 1. It could be about modulators of receptors associated with anabolic signaling, etc. And the results are mixed in clinical populations about these interventions for various reasons. And if you'd like to see all these different approaches, these reviews that go into a lot of detail. But I wanted to focus, because this presentation is more about discovery biology, is to think about other factors that are less well described. And a lot of the work that I'm describing is unpublished work from our team about the role of the DGC in muscle health. So the dystrophin glycoprotein complex, it looks very intricate here, and it is in terms of the connection between the muscle fibers, both in the actual contractile machinery, through these particular proteins that link through the muscle membrane, and these contractile forces here that extend across the membrane to allow muscles to pull on bones and to allow movement to occur. So in addition to these transmission properties of the particular complex of proteins, it's also very important for signaling, as I described previously. So associated with catabolism, for anabolism, and also for adaptations to interventions, including exercise. And this role of the DGC came to prominence, especially in the context of cancer, in particular cancer cachexia, the wasting of muscle and fat in the face of tumor bearing. And what was very clear early on in the tumor bearing scenario is that the dystrophin glycoprotein complex became dysfunctional. There was a loss of integrity at the muscle membrane well before there was significant muscle wasting. And so when we look at this loss of integrity at the muscle membrane, what we find is that we have the membranes become very fragile, they become susceptible to infiltration from the outside into the cell. In particular, ions like calcium can infiltrate the intracellular space, overwhelm the cell's capacity to buffer that change in calcium, and then proceed down a path of proteolysis, etc., that will break down that muscle. So we have muscle atrophy associated with this loss of integrity at the muscle membrane. Later studies have also seen this in an aging context as well. When we compare young versus old, these are in young and old rats, that we saw the dystrophin and other dystrophin-associated proteins being disrupted at the muscle membrane. So in the case of young compared to old, we see a loss of integrity of these critical proteins at the muscle membrane. So if we lose this integrity where force transmission is critical, not only do we have this loss of the transmission of force, but the protection of that muscle from contraction-mediated damage is also compromised. So the loss of dystrophin at the muscle membrane makes the muscle fragile, and if they're susceptible to these contractions, particularly eccentric contractions, then we can get significant muscle trauma. In fact, what studies have shown, and this is from Keith Barr's team, is that this susceptibility to contraction-induced damage was apparent well before there was significant wasting. So the concept that we've followed for many years, thinking about tracking the loss of muscle mass as a key factor, may be less important than, of course, tracking the consequences for muscle function. And I think that's even in the most recent definition, that muscle function is becoming more important in the frontline definition compared with just about muscle mass being front and center. In our hands, in terms of looking at how the dystrophin glycoprotein complex compromises anabolic signaling, we've looked at this in the context of muscular dystrophy and in animal models that lack particular proteins at this particular complex. So in the MDX mouse, which lacks dystrophin but has a replacement protein called utrophin, if we give these mice an anabolic stimulus, and it's a beta agonist called formoterol, in very low doses, micromolar doses, we get substantial increases in the size of the muscles, the tibialis anterior, the extensor digitorum longus, and even slow twitch muscles, the soleus muscles, responding favorably in the wild types and the MDX mouse because it has this other protein that takes the space or the function of the missing dystrophin. Not always completely, but in this case from anabolism certainly present. But when we compare that to another mouse which lacks both dystrophin and utrophin, giving the same anabolic stimulus which caused hypertrophy in the wild type in the MDX mouse, we see no response at all in this DKO or double knockout mouse, indicating to us that disruption of the dystrophin glycoprotein complex is critical for this anabolic signaling. We've also done a number of different studies looking at exercise-like interventions that look at the role of dystrophin and utrophin in mediating these exercise benefits. So what we've done in this context here is use implantable stimulators. So we implant these stimulators underneath the skin of the animal, and we wirelessly stimulate, such as here you can see a very low frequency, 10 pulses per second, to see just that mimicking of an aerobic type exercise, low recruitment of motor unit, etc. But that is sufficient to cause a quite significant adaptation in wild type, in the MDX mouse, and to a certain extent in the double knockout. This is the unstimulated muscle here, this is the stimulated muscle here, which has undergone 4 weeks of low frequency stimulation and pulses per second. And you can see very clearly in the black 10 wild type, in the MDX mouse, and in the double knockout, we have a very red muscle indicating that it's responded very nicely to that endurance-like stimulus. But if we look at the level of adaptation going from changes in the mitochondria through to the protection of the muscle from contraction-mediated damage, the wild type and the MDX mouse respond very strongly to this intervention, whereas the double knockout, it responds, but not nearly as well, not nearly as significant in magnitude compared to when the dystrophin glycoprotein complex had some degree of functionality. So it raises again an important point that if we are subjecting muscles to particular interventions, we have to ensure that the signalling mechanisms are intact, ensure that the stimuli are actually going to produce some level of benefit. And Dr. Christy Swiderski within our team within the Centre for Muscle Research is looking at different ways in which we can preserve this integrity of the dystrophin glycoprotein complex. So for us, our contention is that unless we have integrity of the DGC at the membrane, any effort that we impose to try and address the loss of muscle with age or other serious conditions where wasting is prominent, these interventions could potentially be futile. And so what we're trying to focus on from a very fundamental level is how we can restore the integrity of the DGC at the muscle membrane through various mechanisms. And I don't have time to talk to you about the different genetic ways in which we've been doing this, but suffice it to say that we are getting some very interesting data in terms of even changing particular serine residues on these proteins can actually confer greater acquisition or integrity at that particular membrane. The final set of experiments that I wanted to explain to you from a discovery biology perspective, when we're thinking about interventions beyond the norm. So there's a wealth of evidence to suggest that exercise and nutrition, and even in some cases, various hormonal interventions may have some benefits and others may have other benefits as well. But if we really want to offset these changes, if we really want to prevent significant changes in muscle homeostasis, then potentially we may have to change those attributes within muscle that allow the muscle to be protected. In the context of muscle disease, the question we relate in particular is, can we change muscle size or can we change muscle metabolism to actually protect the muscle from significant pathology? And in the same context, it's related to, can we change a muscle's attributes to protect it from aging? And from a theoretical perspective, we believe that we've got some pretty clear evidence that that is possible. So what sort of attributes am I talking about that will improve muscle health with age? So I think what we want to do quite clearly is that we want to preserve muscle mass. I don't think we necessarily have to increase it, although that may be a benefit in many situations where we've got diminished muscle mass. So if we have a preservation of muscle size, therefore, hopefully a functional correlate that improves muscle strength. But in addition to that, in terms of the tasks of daily living and independent living through various means, is fatigue resistance. We don't want to go through these tasks and be exhausted. We want to be able to maintain quality of life for as long as possible. So from a functional independence perspective, and also for workers that are being asked to work for longer for various reasons in terms of changes to the retirement age and so on, we need to have bodies that can actually withstand the rigors of working long days, etc. So the other important aspect, especially in relation to the most recent investigations into the aged care system in this country, is that if we can produce ways to delay someone going into a nursing home, that's going to have a significant benefit for the community in many different ways, but fundamentally for that individual. So our wish list, we're in control of this. So remember that we've got various ways in which we can manipulate muscle attributes. What should we do to preserve muscle health relevant to aging? And the wish list I've put forward here is that, well, we want to preserve strength. That's pretty key. But we also want to improve the resistance to fatigue. So we want larger oxidative fibers. So it seems like a wish list that should be achievable. Except that nature doesn't necessarily allow us to do that quite easily. Across all species, from mice through to humans, there is the relationship is basically saying that as muscle size increases, oxidative capacity diminishes. So as muscle size will hypertrophy, typically we go from this relationship here from highly oxidative, more blue fibers to larger, whiter, more glycolytic fibers. So this relationship here in terms of phenotype versus oxidative capacity Smaller going to larger means there's a diminished return in terms of oxidative capacity. So there's a trade-off between size and oxidative capacity. So one of the ways in which we're trying to address this, and if we could address this, is that potentially if we push this relationship here, if we push this relationship to larger, more oxidative fibers, the benefits are firstly for healthier aging, because we've got the capacity to perform tasks for longer without getting tired. Benefits for enhancing work performance, so ways in which we can think about workplaces and safety in the workplace. And also, and this may be the initial test bed for us in terms of advancing these across the species, is that we may also be able to manipulate these parameters that may produce benefits for livestock production in terms of meat quantity and quality, in terms of manipulating the composition of muscle. And that may also relate to cellular agriculture as well, in terms of creating muscles from scratch without the need to kill an animal. So how might we achieve this? I don't have time to go through all the different technologies that we're doing to drive these particular attributes, but we are using recombinant adeno-associated viruses to drive the expression of particular genes that will control muscle size and muscle oxidative capacity. In particular, through this collaborative team, we're looking at improving the size of muscle through overexpressing follistatin in an animal, particularly a mouse model, and that will be in relation to wild type through to various disease states, and also in an aging context. And from an oxidative perspective, much of the data that I showed previously with our low frequency stimulation models, through a range of different transcriptomic analyses, we identified estrogen-related receptor gamma as one of the most highly expressed genes following our exercise protocol. And so what we're trying to do now is to try and manipulate these genes singularly and also in combination to try and produce muscles that are both larger and more oxidative. And this is the plan of attack, and this is sort of the starting point that I sort of would like to follow with you as the story unfolds, trying to think about using this very innovative technology where we manipulate the expression of particular genes within muscle to drive the expression of either larger muscle fibers or more oxidative muscle fibers, or the combination of both larger, more oxidative muscle fibers. So the design could be sequentially looking at individual genetic manipulations, or the combination. We could look at whether the sequence of these interventions, so starting with a follistatin, a growth followed by an oxidative intervention, produces the desired attribute. Remember, these are the sort of potential ways in which we could get an outcome. It could be a smaller, more oxidative muscle if we drive estrogen receptor gamma. It could be a larger muscle if we just drive follistatin. Or ideally, in terms of our wish list for healthy aging, it could be larger, more oxidative fibers. And so manipulating these variables, also in conjunction with our exercise protocols, may hopefully lead to these particular phenotypes that would be relevant in the context of healthy aging. So our view is that if we have this capacity to remodel muscle, remember this is discovering muscle biology, some ways from clinical application, but it all starts here in terms of discovery, that we have the capacity to remodel size of muscle, we have the capacity to remodel the metabolism of the muscle, potentially can protect muscles and muscular health in disease states, so various cases of muscular dystrophy, in cancer settings where some of these, the holes in the bucket are quite significant, and of course in relation to healthy aging, in relation to sarcopenia. Finally, I'd just like to acknowledge the Centre for Muscle Research and this wonderful team of investigators pursuing these particular discovery muscle questions, and to thank our sponsors as well. And I must say, I'm sorry for the technical difficulties. You wouldn't believe the sort of issues I've had since I started. I lost my internet connection. My son was doing an exam at the same time, so I couldn't restart the internet, so I was pushed onto this small little laptop. So apologies for the technical difficulties. I hope the story was still conveyed with some lucidity. Thank you very much. Thank
you very much, Gordon. Hopefully the exam, that is much more important of your son's exam, is going well. And hopefully we didn't use so much bandwidth.
Well, the exam is over now, but I was too scared to restart, which is why I stuck with this. But I suspect I paid the penalty with the technical issues. So again, hopefully the story was still conveyed.
Our dietolic Susan Curl is saying that you're doing an amazing job. So if you have any questions for Gordon, please raise your hand, unmute yourself, or put your question in the chat. I don't see questions. Yeah, we have one. Excuse. While preparing that one, Gordon, can you maybe tell us how you would see in a perfect world how the biology of muscle aging could work together with the clinical science of doing randomized controlled trials, and how the ANZSSFR could help bridging really the biology and the clinical field?
Yeah, I think there are many studies that have not been optimized. If I even talk about the hormonal interventions, if we think about anabolic interventions, and many of the different trials that have been undertaken, many things have been rushed to clinical application without the proper, this is my bias, the preclinical evaluation that really, to determine the mechanism behind how these interventions will work. This is the same. It's not just the field of aging; it's the field of muscular dystrophies and cancer that I'm so closely involved with. So many things have been rushed to the clinic without proper evaluation, and we pay for that later. And so I think if we can do these things in a more rigorous fashion, sequentially through the preclinical step through to the clinical translation, then I think we've got a much stronger argument to say that these interventions have merit. But at the moment, there are so many things that have been rushed that I feel the efficacy, the potential there, but the efficacy has not been demonstrated, largely through many of the shortcomings that could have been, I think, obviated from the outset.
Yeah, thank you. Christopher Oliver has a question with regards to type 2 fibers versus type 1 fibers. What brings the bigger problem during the aging process? And then we go to a question of Professor Hayes, who raised his hand.
Okay, so it's well established that the fast type 2 fibers are more susceptible to many of these conditions associated with wasting. That goes not just with sarcopenia, but it's also with muscular dystrophy and so on. The type 2 fibers, the larger fibers, those that produce more force, tend to be the most susceptible to wasting conditions. So the view that I've had many in sort of previous years has always been, well, let's make the muscle bigger. Let's try and make sure we preserve these muscle fibers as best we can. I think the preservation is fine, but making muscles certainly much bigger doesn't necessarily hold. I think the idea of preserving function is the key. And we can still, if we think about the spectrum of fast fibers, from the fastest contracting fibers, that could be the 2X fibers in humans or the type 2B fibers in other mammals, there are other fast subtypes that have also an oxidative status in addition to being glycolytic. So the type 2A fibers, I think, hold promise. And that's where I've sort of shifted this idea of the attribute, that if we can preserve muscle size, a fast fiber population, for most activities of daily living, we don't necessarily recruit all the motor units that are necessary. And in fact, most people throughout their life can never recruit all their motor units for any particular task, which is perhaps quite sad. And I think in terms of the interventions that Maria described previously, that recruitment of that fast fiber pool is part of the key, I think, to preserving muscle health. So preserving the fast fiber pool not necessarily has to be about fiber size. Preserving size is important, but the growth of the anabolism, many of the interventions I've done previously, I don't think are as essential as preserving function. And with that, I think the preservation of oxidative capacity is very clearly becoming for longevity and for other things that preservation of oxidative capacity is critical. So the combination of preserving the fast fibre pool of a more oxidative status, to me, has some merit. And I'd like to think that that is something which may also preserve that population rather than losing them as being the most susceptible ones with sarcopenia and other conditions.
Okay, thank you. Professor Hayes, Alan.
Thanks, Andrea. Great talk as always, Gordon. Just in relation to the idea of trying to get sort of big fibres that are strong but also more oxidative, how much of the limitations in those sizes really come from capillarization and then being able to get those the level of diffusion really which limits the size of the muscle fibres? So even if you can make them more oxidative to begin with, is it sustainable if you can't actually get more capillarization around the muscles?
Yeah, I mean, in terms of preserving and preventing anoxic cause, clearly we need to get delivery. Part of the oxidative program may also relate to capillarization as well. We know that as the muscle fibers grow in terms of the glycolytic status, the number of capillaries diminishes. If we can also have it, we're trying different things. I can sort of give some insight into some of our myoglobin work. We're trying to overexpress myoglobin. We're also trying to think about ways in which we can increase capillaries to muscle. But the limiting factor, if you think about that graph that comes from Richard Jaspers in Amsterdam, is that even some very, very large fibres, from Ranapipians in the frog, massive fibres, are still sustained and not necessarily well capillarized either. So within nature, there is the ability to sustain large fibres. If you look through the literature, much of in the muscle field, we think about capillaries on the outside of fibres, but there is actually in cardiac tissue and in some cases, I know of one study in skeletal muscle where we've got capillarization running sometimes even through fibres, and that's not well documented, but it is in the literature. So I think some creative ways about preserving muscle health will also be about preserving that oxygen delivery and that waste removal. But there is evidence, I think, in nature to say that larger fibres can still be sustained without necessarily having all the number of capillaries that you would think would be needed to supply it.
Thank you. I see another hand, Professor Levinger, Itamar.
Hi, Gordon. Really nice talk. Just from practical point of view, with all drugs that people trying to develop to target increased muscle mass and strength, but particularly the muscle mass, what are the strategies to try to make them specific to skeletal muscle? Because what we don't want is to have them effect on all muscle, and then you can have, like hypertrophic cardiomyopathy, for instance, on something like that. So you treat one conditions like sarcopenia, but then you create other problems in the heart. How can we actually, or when you design a drug, for instance, how can you make this distinguish between different type of muscles to eliminate side effects?
Yeah, it's a very good question, and one of the practical limitations of many of the anabolic strategies, and myself and Alan Hayes and others that have looked at this in some of the anabolic drugs, the off-target effects, particularly on the heart, can be quite limiting. What we're trying to do, Itamar, with the development of these particular strategies is to use promoters that drive expression solely within skeletal muscle. So we were able to test the strategy, the theoretical strategy of just addressing the muscle question alone. So this is the genetic interventions allow us, and we can do this in various ways. We don't necessarily have to switch the signal on from the outset and the animal maintains that signal. We can use various strategies where we can use tetracycline to switch that signal on. We can also switch that signal off at various stages of the lifespan. So what we're expecting is that if we're thinking forward about discovery biology and its potential future application, it's not a case of whether we might be necessarily intervening throughout the entire lifespan to prevent. It could be at specific times we can switch on that gene that allows the expression or diminishes the expression of certain genes that allows muscle to be maintained, and it is still targeted to the tissue in question. So the potential there is to keep it to where it needs to be without the off-target effects. So the strategies that we've got in place, I think the first test bed will be in animals for livestock. We're thinking about different ways in which we can slowly release different factors, switch them on. It could be only for a certain portion of the lifespan to increase mass or change different properties that will improve oxidative status to make the muscle more tender, etc. All that relates to livestock production. But it's all about how we can keep it to the tissue in question. So these genetic strategies that I've said are about muscle-specific overexpression as opposed to body-wide systemic expression, where we might think every striated tissue, including the heart, gets affected and the whole thing comes undone.
Thank you.
Thank you. Yeah, I don't see more hands or somebody unmuting. So thank you so much, Gordon and Maria, for these wonderful talks and sharing your expertise. So your widely really renowned expertise with us. I think this was a wonderful discussion. And we will now proceed to the annual general meeting of the society. One point, it seems that a couple had problems with getting into the Zoom. So we will circulate an email, circulate a link to the recordings. So hopefully nobody disagrees. Sorry, I should have asked that this meeting will be recorded, but you actually said yes, and you knew that it was recorded. So thank you very much for the non-members that you participated in this meeting. And the non-members, please see if you would like to become a member. This is very important for our society, and wishing you a very nice evening. And I would like to ask the members to stay for our AGM.